Hello everyone. I'll be continuing today with my talk about meningiomas. There are several images that I did not use in my prior talks because I did not have the reference for the beautiful pictures, but I finally found the reference, so I'm adding these few slides. This is a classic appearance of a false meningioma showing the deformity of the corpus callosum and the singular gyrus. This can only happen from an extraaxial mass, such as a false meningioma or maybe a large exophytic brain tumor. And you can see again that these changes can be seen when we used to do angiograms showing the deformity of the pericallosal artery, again only seen with extraaxial lesions and the curvature of the vessels here. The other image I want to show is this deformity of the anterior cerebral artery by this large meningioma of the olfactory groove in planum sphenoidale. And you can see on an angiogram the classic deformity of an extraaxial mass, as well as on the MR, this kind of deformity. And again, this diagram shows the large meningioma covering the entire floor of the anterior fossa. And again, we can see the similar appearance here of this very large meningioma on the sagittal MR. I just want to show that Nate sent me this case. He saw it 1/2 hour or an hour after I gave my last talk. And again, I want to show a calcified small meningioma that Nate sent me, a large calcified meningioma of the tuberculum celli, on MR, a small tubercular meningioma and a large one. And on the diagram by Cushing, we can see the progressive involvement of the chiasm being deformed by this increasing size tubercular meningioma. And that's why these lesions are important for visual issues. Now, I've so far covered convexity, parasagittal, falx, olfactory groove, planum sphenoidale, tuberculum celli, and last week I talked a little bit about the anterior clinoid and the importance of these lesions for visual issues. I want to spend some time on this case that was read as invading the cavernous sinus. This is a meningioma of the anterior clinoid. Now, I want to point out that the cavernous sinus is not invaded here. It's just resting on the diaphragm celli. Let's look at this sagittal, beautiful dissection from Bassett's atlas showing the carotid siphon coming out of the temple bone and then going anteriorly within the cavernous sinus and then turning around here, making this kind of S-loop, and then comes out of the cavernous sinus where the ophthalmic artery comes off. I put a black line to show what this would look like on the coronal plane. So here it is, a coronal anatomic dissection showing the chiasm, the loop of the carotid artery that is already in the subarachnoid space, the anterior clinoid, and the carotid artery loop within the cavernous sinus. And here's the diaphragm celli over the pituitary gland. And if we go back to this lesion, again, we see the carotid within the cavernous sinus, the carotid that came out of the cavernous sinus, like here, and here's a tumor resting on the diaphragm celli and did not invade the cavernous sinus, because that makes a big difference surgically, because you cannot really operate within the cavernous sinus. So this was just resting on the diaphragm celli and did not invade the cavernous sinus. And again, last week I showed small meningiomas on the lateral aspect of the anterior clinoid. These really don't have any effect on the visual system, but if they get large, they can affect Broca's area, and that's why I show them this again, because I didn't mention last time. Here's a patient showing optic atrophy on the left side, resulting from this very prominent large meningioma around the anterior clinoid on the left side, and we can see the left optic nerve here being compressed and deformed by this meningioma invading the optic canal. Here it is on the coronal plane with a marked hyperostosis of the clinoid. Here we see the right optic nerve, which looks okay, like on this T2 image, but here we see the tumor within the optic canal and cannot even identify the optic nerve. This explains why this patient has optic atrophy as seen in the orbit on the coronal view. Now, this is an unusual condition that occurs with anterior clinoid and tuberculum celli meningiomas. That is, externalization of the sphenoid sinus. And as you can see, this was on a plain film, not the same patient, but here we can see prominence of the air cell of the sphenoid. And here's the same patient on the MR image, on the coronal post-gatto. Notice this is the clinoid markedly pneumatized with a nerve trapped within it. And that's because this patient has an anterior clinoid meningioma with what is called Pneumosinus Dilatans. And if we look here, let's look at the normal coronal CT. So again, as I've said many times, the clinoid is laterally. Medially, we have the optic canal with a very thin bony roof. In comparison, this patient that has this anterior clinoid meningioma has marked pneumatization above the optic canal and also below it. So the optic nerve is kind of trapped between these two expanded air cells, and sometimes they'll cause visual symptoms and they have to kind of decompress this area. And again, here it is on the sagittal view. Here's the meningioma, and here we see the nerve trapped between this expanded sinus. Here's another case of a very large anterior clinoid meningioma. Note the expansion of the sphenoid sinus into the clinoid, and we can see here on the coronal CT, notice this is a markedly enlarged air cell of the sphenoid surrounding the optic nerve within it. Here's another case of a smaller anterior clinoid meningioma, pre and post contrast. And if we look at the axial CT, we can see how this clinoid is pneumatized much more in comparison to the other side. And here, if we look, there's pneumatization of the clinoid and also the optic strut, which is the bony bridge connecting the clinoid to the body of the sphenoid, is more pneumatized than the opposite side, although normally it can be pneumatized, as you can see here, again, a clinoid and a pneumatized optic strut. Again, on this anatomic specimen looking from behind, again, the clinoid laterally, optic canal. This is the bony strut, like a bridge between the anterior clinoid and the body of the sphenoid. Now, this excessive pneumatization can also involve the sphenoid sinus itself. Here's a large meningioma of the tuberculum celli, which is grouped back behind the sella. And notice the height of the sinus usually should be at the same level as the planum, as the olfactory groove. This is expanded, again, Pneumosinus Dilatans, secondary to this meningioma. Here's another case with a large meningioma of the planum sphenoidale, grew backwards over the sella, involving both optic canals and are invaded by tumor. And we can see again that the sinus is expanded upward, again, should not be so high above the level where the uh, olfactory groove sits. And again, notice the tumor is within both optic canals and the very large sinus also in the coronal plane. Okay, what is the finding in this patient? Correct. As Gino says, we see enhancement of the left optic nerve. This is an interesting case of a young patient who failed the driver test because of visual problems in taking the exam. And as Gino points out, there was enhancement. So now I'm moving on to another type of meningioma, those involving the sheath of the optic nerve. So again, if we go back to this case, enhancement of the optic nerve here. We also see the optic nerve enhancing here before it enters the optic canal. So it would be this segment here as it enters the optic canal. Notice also that the clinoid on the left side is a little larger than this side. And it's all again obvious on the coronal plane, again on this anatomic specimen, clinoid optic canal. And this is, and we can look here on the MR images. Notice, first of all, the enhancement of the left optic nerve here. And the clinoid is also a little bit expanded. The black is the cortex. Look, this clinoid is much larger than this clinoid. And again, enhancement and expansion a little bit of the optic nerve. And within the orbit, we see the enhancement post-gada of the optic nerve, and again, optic nerve here. So this is an optic nerve meningioma. What side is the abnormality here? Correct. As Gino says, on the right side, kind of a classic maybe board case, and we can see the enhancement, the so-called tram track sign, classic for an optic nerve meningioma. In addition, there's also enhancement here of the chiasm, and we can see it here. Here's the chiasm, the two optic nerves. So this is also enhancing on this page. And again, on the coronal plane, we can see the enhancement surrounding the optic nerve. And this is an interesting case of an optic nerve meningioma because we can see again the enhancement within the orbit, but also here we can see it surrounding the thin optic nerve, compressed optic nerve within the optic canal. A little unusual to see this entire nerve like this. This is what we usually see, but this is more unusual. And again, on the coronal plane, note within the orbit the marked enhancement of the optic nerve. And this is again like a board case, the typical expansion of the meningioma around within the sheath of the optic nerve on the sagittal view. Here it is on the coronal view, and again, the marked enlargement around the nerve. Remember that the dura extends because the optic nerve is an extension of the brain into the orbit. The dura of the brain also extends into the optic canal and the orbit, and that's where we get these meningiomas of the optic nerve within the orbit. Now, here are two cases, one of which is an optic nerve meningioma, the other one isn't. Any guess which one is not the optic nerve meningioma? Right or left case? The right is the optic nerve meningioma. This is the the giveaway signal, I would not choose from the literature another optic nerve meningioma. We have enough. This was a very unusual case of cryptococcal meningitis with perioptic neuritis, looking very similar to this meningioma. Here was an interesting case. This patient had Gamma knife for a pituitary tumor 11 years prior to this study, and we can see on a follow-up study, you could see that there's enhancement of the sheath around this optic nerve, possibly some sequelae of the treatment or the radiation treatment. And again, we can see a little bit of enhancement around the optic nerve on the coronal plane. This is a very unusual case we had. This patient had some renal failure, had a whole bunch of medical issues, and came in, had no visual symptom. This was a study of the brain because she developed some cognitive disorders. And look at the marked enhancement of both sheath of the optic nerves. And also of note was that there's significant enhancement of all the dura surrounding the brain. So the differential in this case would be lymphoma, some sort of metastatic disease, sarcoid, but the patient had no, and was followed, there was no suggestion of any abnormalities of that sort. So we left with this possible diagnosis. Maybe this is idiopathic hypertrophic plaque meningitis, also known as IHP. And remember, I've shown in the past a case that had advancement, within the posterior fossa of the dura, in the orbit, in the orbital apex, and also involving the dura. And this, again, is a rare condition of unknown origin. It has either localized diffuse fibrosis and inflammatory inflammation of the dura. It's usually associated with rheumatoid arthritis, Wagner's, granulomatosis, TB, and cancer, and also sarcoid. But this patient had none of that. So this is possibly the etiology in this case. Okay, here we have, let me put it mildly, a prominent lesion. Any possible diagnoses? Anybody? Okay, somebody mentioned meningioma, Ben, and Gino mentioned a meningioma. That's a very good diagnosis. One of the issues here was, was this a meningioma or was this a massive tumor of the pituitary? And that was the differential. Patient was blind, 39-year-old patient, blind. Does the MR help in the differential? Does it look more like a meningioma or adenoma? I think that the main finding here, there's enhancement, which both of them can have. I think the diffusion image showing the marked restriction would go more for meningioma, which is many times will be quite restricted on diffusion. The patient then underwent a CTA, and the feeling then, the CTA was read out as not likely to be meningioma because there was not this typical marked enhancement. However, we have to point out two things. That this is not a markedly expanded cella. This tremendous erosion of the sphenoid here. And then we see a little bit of hyperostosis. This is not the tuberculum celli. Note, which was not appreciated at the time, these vessels here. See these vessels I've talked about many times that supply meningioma, and in this case, remember I showed this last week, that expanded ophthalmic artery showing the supply of meningiomas in the floor of the anterior fossa. Because these are ethmoidal branches coming off the ophthalmic artery. These ethmoidal branches supply the anterior meningeal arteries, which supply the floor of the anterior fossa, let's say of a olfactory groove meningiomas, like in this case on the angiogram. And I showed that we can see it on a sagittal mound, this large meningioma. Again, seen here in the coronal in the hyperostosis. And again, another case showing the hyperostosis, which occurs, as I mentioned last week, in the suture between the sphenoid and the ethmoid. That is the sphenoethmoidal suture. This is where the ossification or the calcification starts, and notice the tumor grows around it. So if we now go back to our case, and we see these vessels coming out of here, this is not the tuberculum cella. They used to be here someplace. There's marked erosion of the body of the sphenoid here and the sphenoid sinus. Notice if we look at the coronal where the hyperostosis is, here we only see ethmoid air cell. The sphenoid is all destroyed. And that explained why we see these vessels coming out from this area of hyperostosis. This is way anteriorly now. This is not the tuberculum. This is the region of there used to be the sphenoethmoidal suture. So these vessels are a giveaway for this being, again, a meningioma. And this was operated on and was a meningioma. So these vessels are can be quite helpful. Okay, so we've covered all these various meningiomas so far. Now we're moving to an important area, the sphenoid ridge. Now what is a sphenoid ridge? The sphenoid ridge is kind of a sharp edge of the bone separating the anterior fossa from the middle fossa. And let's review a little bit of the anatomy. And Cushing has divided the meningiomas of this location into three, and I'll go into this a little later. I just want to review the anatomy of the sphenoid bone, which I've talked about before. It's a very important bone. It has many foramina in it and is involved with many cranial nerve issues, but also with meningiomas, as we've seen and will see. So far, I've talked about the planum sphenoidale over here, the tuberculum cellae, which I covered last week, the optic canals, and the anterior clinoids. I've talked about the superior orbital fissure, the foramen rotundum, the pterygoid canal, and the foramen valley, and all the various nerves that are involved that go through these foramina. Now we're going to talk about the lesser wing, the greater wing, and other structures that we have not covered as yet. If we look at the isolated sphenoid bone from behind, this is the lesser wing of the sphenoid. So the tuberculum cell would be here, and this would be laterally. Again, this is superior orbital fissure, foramen rotundum. This is the back here, the dorsum cellar region. And if we look at the isolated sphenoid bone that I radiographed here, and again, in a similar view, again, we see the lesser wing of the sphenoid here. This would be the optic canal. This is the greater wing. This is the greater wing of the sphenoid looking from behind, where the floor and anterior wall of the middle fossa. So if we look at this coronal CT, this is the lesser wing of the sphenoid, and this is the greater wing. And again, on a plain film, which we rarely see anymore, this is the lesser wing of the sphenoid. This used to be called the nominate line. This is the greater wing of the sphenoid and this projection. And again, on this anatomic specimen of the isolated sphenoid. This is the lesser wing, and this is the greater wing. The lesser wing is a delicate structure, very thin, and it kind of sometimes extends a little further, sometimes less. Okay, we have 3 foramina here. Would you please name those 3 foramina? Which is the red, which is the yellow, and which is the green? Let's start with the red. Correct, as Gino says, this is the foramen spinosum, where the middle meningeal artery goes through. What is this one in yellow? Foramen ovale, correct. Now we come, what is this green arrow pointing to? A foramen that has not been mentioned so far. Rarely seen. Correct. Congratulations to Gaurav, foramen Vesalius. This is a foramen Vesalius, also known as sphenoidal emissary foramen. The vein of Vesalius connects the pterygoid venous plexus with the cavernous sinus. Here it is, you see in Gray's atlas, it's called the emissary foramen, but was named either by or after Vesalius. And that it's rarely occurs, however it's there, sometimes may be bilateral. The importance of this vein going within it is sometimes infections from the pterygoid plexus can enter the cavernous sinus. So this is one possible route of this infection. And here it is, here's a case showing on the CT the foramina bilaterally, and here's an MR showing the enhancing vein within the foramen Vesalius, and we can even see it here in the coronal plane. Here's the vein connecting with the pterygoid plexus. Here on the sagittal plane, we can see the vein going towards the foramen Vesalius. So this is that foramen. Okay, now let's talk about meningiomas. Cushing divided meningiomas of the sphenoid ridge into 3. The first one is the clinoidal meningiomas, of which we can see an example here, a diagram, and also by this netter. These are very difficult meningiomas, and most of the time will be left alone, at least the medial aspect, because you can see how it'll involve eventually the cavernous sinus, involves the optic chiasm, the optic nerves. So this is really the most dangerous meningioma, and these are called clinoidal meningiomas, as you can see in this picture over here. And because I've shown these, I'll just show again this lateral clinoidal meningioma. This is the most serious that I showed before. These are clinoidal meningiomas involving the medial aspect of the sphenoid ridge. Another case of a clinoidal meningioma, again, notice involving, like in this picture here, we can see how it's encasing the carotid artery and the nerves. So this whole area, the medial part of this lesion, is really inoperable. This is an unusual case of a middle sphenoid ridge meningioma, which Cushing called alar. Now why alar? Because in Latin, the lesser wing of the sphenoid is called ala minor, and the greater wing of the sphenoid is the ala major. So this is ala major and ala minor. So these are 2 separate cases. This is an MR and this is a CT on a different case. These are rare lesions, and you can see involves the middle part of the sphenoid ridge. One of the problems I'll show later, there's most of the sphenoid ridge meningioma, by the time they come to be diagnosed, are quite extensive, and this distinction of 3 separate areas doesn't hold in many of the cases, if not most of the cases. Okay, now let's move to the outer part of the ridge called pterional meningioma. Here's a very unusual case of a tiny pterional meningioma, incidentally seen on an MR study. Now, what is the pterion? Very interesting. There are 4 bones that meet on the outer surface of the skull: the frontal bone, the parietal bone, the outer surface or the greater wing of the sphenoid, and the squamosal portion of the temporal bone. They normally form this kind of an H here. So this is the region of the pterion. Why is it called pterion? The name came from a Greek origin, pteron, which means wing. In Greek mythology, Hermes, messenger of the gods, was enabled to fly by winged sandals which were attached in this area, and also he had them on his sandals. There are many statues all over the world that show a statue of Hermes with his wings. I could not download one from the internet to show you because there's all kind of issues to download. You have all these advertisement stuff. But anyway, I'm sure you could find it easily. And it was considered the weakest part of the calvarium. It also, the importance of this area is because it's a very common, some people say most common neurosurgical landmark for putting burr holes here to expose the floor of the brain for various types of surgeries. Now, one of the issues here is, as shown in this study, there's a lot of variation in this area. There's a bunch of sesamoid or worming bone that occur here. They're called epipteric bones. So there's variability here, and it's important from a neurosurgical point of view because when they put this initial burr hole in this location, they're very close to the orbit. And if this area moves forward, they're in danger of entering the orbit. This study, they looked at about 300 skulls, and they show here the variations. For instance, this is the normal H, but sometimes the frontal bone and the temporal bone will touch, and the parietal and sphenoid are separated. There are all these variations. And here they show the variation of the epipteric bones. So there's some variability here. And again, if we look at this bone diagram here, so in yellow is the sphenoid. This is the area of the pterion, where the squamosal portion of the temporal bone meets the sphenoid, the frontal, and this is the parietal, and the blue is the squama of the temporal bone. Remember, it's a little curved because of the subtemporal region. So this is the area of the pterion. Now, why is the pterion so important? Because the middle meningeal artery runs, once it enters here, it runs right near the pterion. Note beautifully on letters, here are the various sutures that I just pointed out on the outer surface. That's where the middle meningeal run. Also, this dissection by Bassett, this is the intact dura. Notice that the middle meningeal artery branches run on the outer surface of the dura. Okay, what is this case and why am I showing it? Maybe for a resident. What is wrong with this patient? He fell for a height of 15 feet. Correct. As Kier says, an epidural hematoma, a classic epidural hematoma. And notice here, here's the fracture line. What is the fracture line crossing in this location? It's crossing the region of the pterion. And remember I showed before The middle meningeal runs in the inner part of the pterion and is easily damaged if there's a fracture. And this is why this patient had the epidural hematoma. This was a CTA study, and I think that this may be, I cannot prove it, but I think that this is the middle meningeal artery here being displaced by this epidural hematoma that we can see on the CT. So that's the importance of wide trauma in this location can end up with epidural hematomas. So here we now go to the third type of meningiomas, the so-called pterional meningiomas. And here's a classic example. Notice it's quite large. As you'll see later, the problem that many cases will involve all three areas because of the time it takes for these cases to be diagnosed. You know, somewhat of a silent neurologic area. So these lesions get quite large before they come to diagnosis. What are this old-fashioned angiogram from the old days prior to CT show? Correct. As Gino says, markedly enlarged selective injection of the middle meningeal artery, showing it's enlarged, supplying a tumor here, and again middle meningeal here, showing the striations I talk about of the vessels, the so-called radiating or sunburst appearance of the middle meningeal branches, classic for meningioma, and we see the middle cerebral artery markedly elevated, again curved, classic for a very large sphenoid meningioma or pterional meningioma. And here's a case we had, and here's the CTA. Again, the normal position of the middle cerebral, markedly elevated, not as nicely curved here, but we still markedly elevated. Again, in this anatomic diagram, the horizontal position of a normal middle cerebral, which is markedly elevated. And here's the middle meningeal on the floor of the middle fossa. And here we can see how it's markedly expanded. And this anatomic specimen from the literature shows this marked meningioma. So again, a pterional meningioma, which is markedly enlarged and not involving a large portion of the sphenoid ridge. And here's another pterional meningioma, again quite large, with some involvement of the bone that I'll talk about a little later. Again, notice that in this meningioma, we again see the vascularity coming off the middle meningeal. Here are these striations. These are the middle meningeal branches supplying the tumor. And here's a tumor, maybe a little supply from the middle cerebral artery. Remember, the outer surface of the tumor usually gets a carotid supply. Again, here's a the MRA showing the middle meningeal artery, quite prominent branches here. We barely see them on this side. They're enlarged here, and he has some branches supplying the tumor. Okay, what's wrong with this case? Very good. As Gino says, unplaque meningioma. Correct. Let's talk about unplaque meningioma. And this diagram here, which I've shown before, the various type of meningioma. Unplaque meningioma is a thin plate of soft tissue meningioma and marked bony changes overlying that. And here's a picture from Osborne's book, where from another source, showing an unplaqued meningioma in the floor of the anterior fossa. So what are we seeing here? We have to go through the anatomy a little bit here. So again, this is the sphenoid ridge, or the lesser wing of the sphenoid. If we look at this anatomic specimen, the interesting thing about the greater wing of the sphenoid, that it has, here's a radiograph from an isolated sphenoid that I did, looking as if you're doing a axial CT or an axial MR. So the greater wing of the sphenoid has two surfaces: an anterior surface which forms the posterolateral wall of the orbit. That's this surface. Then there's this curved surface. This is the anterior wall of the middle fossa. In between is bone marrow. So here on this anatomic specimen, you can see the bone marrow. And here on the normal MR, all this fat on the T1. So this is the anterior margin of the greater wing, forming the posterolateral wall of the orbit. And here it is, forming the anterior wall of the middle fossa. So what has happened in this patient? This thin layer is this unplaqued meningioma, but the major change involved the bone. Look at the tremendous expansion of the greater wing of the sphenoid compared to this side. So there's tremendous enlargement of the bone due to this invasion by the meningioma, with a very thin layer of soft tissue outside the bone. And look at the hyperostosis on the same patient seen on the CT. Marked hyperostosis when you compare it to the opposite side. And that's classic for these lesions. Here's another case. Which side is abnormal here? The right. As Ben says, Anshu says. See, here's a normal lesser wing of the sphenoid. Look, it's thickened over here. A thin layer of meningioma, but markedly thickened bone. Look at all the enhancement here of the greater wing of the sphenoid. What is enhancing here? What is this linear structure? Correct. As Gino says, the temporalis muscle usually will show abnormalities. I don't think it's a tumor invasion, but it's just a reaction to the meningioma. And again, notice on CT the marked expansion and involvement of the greater wing and the lesser wing compared to the normal side. Again, that's the issue with the pterional meningiomas, that most of the time when they come to diagnosis, you really cannot divide into the thirds. The whole lesser wing, the whole greater wing are involved. Maybe the clinoid may be spared, although here we can see the clinoid is also involved. So sphenoid ridge meningioma, by the time we get to seeing them, most of the time will involve the entire sphenoid ridge. Here's another case with more, now there's more tissue encroaching on the orbit. Again, the marked expansion of the bone. This patient had proptosis. You can see why. There's marked encroachment on the orbit by the expanding bone, the posterolateral wall of the orbit, and also more unplaqued, thicker unplaqued. And in this case, not only did it go all the way medially, but it also crossed to the opposite side along the floor of the cellar, where there is a lot of veins and stuff, so it's easy to cross over. And also this actually went down the cavernous sinus all the way to the foraminal valley. And note again on the same patient the tremendous hyperostosis of the greater wing and the lesser wing of the sphenoid in all projections. It was an unusual case, again, of a pterional meningioma marked expansion of the bone, but here the involvement was more laterally, and it grew into actually the temporalis muscle soft tissue and kind of broke through, presenting as an extraaxial mass. And note the erosion of the bone here, the frontal bone and the sphenoid by this meningioma. Look at the tremendous thickening of the temporalis muscle here. And this is just to show it may be no longer on plaque, or let's say a thick plate or stack of plates. Look at the marked deformity of the lateral rectus and the encroachment on the orbit. And look at all the bone. Again, this is the same patient. Tremendous hyperostosis. Here's an unusual case of a meningioma of the sphenoid ridge where the bone does not show marked thickening, but there's a lot of tissue. So this is a different variety where there's a lot more soft tissue than bony involvement. And here we have a sphenoid pterion meningioma where there's a marked involvement within the expanded bone, and then we can see the rest of it here enhancing. So this part is all within the expanded greater sphenoidal wing. And here's a pterional meningioma, again expanding medially, but also extracalvarially. This tumor has now eroded through the floor of the middle fossa and is now in the subtemporal region. Still showing the expanded bone. This was a massive pterional meningioma that was both in the anterior fossa and the middle fossa. You can see it here on the MR and on the CT, and there's erosion of the bone here. But I want to point out that on the MRA, what we see, this is the ophthalmic artery, and notice this little branches here. Again, little branches, and again, as I mentioned last time, these are the, or also earlier, these are the ethmoidal branches supplying the floor of the anterior fossa. And because this meningioma is also extending along the floor of the anterior fossa, we see some, I think likely these are the ethmoidal branches supplying the floor of the anterior fossa. Now, one of the problems, this case was read as a small meningioma involving the medial part along the cavernous sinus. People read that did not really look at the old studies because this was a post-op study, and this was how it looked preoperatively. So this was just a large sphenoid ridge meningioma, and this is what was left. As I said earlier, you cannot operate medially because you cannot operate on the cavernous sinus because it's causing tremendous damage, entering the veins, bleeding, damaging all the nerves. So people usually will stop at this location. So this is the remnant of a large meningioma. This is not de novo, this is just a residual. Okay, what do people think about this meningioma? This is a trick case. I'm starting with my trick cases. This was not a meningioma, but looks like one for sure. And correct. Asif hit the nail on the head. This was an epidural hematoma simulating a meningioma. How about this pseudomeningioma? Another possibility. No more epidurals. I'm finished with epidural. Met. Correct? As you can see, the bone windows show no involvement of the greater wing of the sphenoid. This patient had an MR 1 month before where these lesions were not appreciated. Anybody see any abnormalities here? Correct? Dural thickening. What else? What about the bone that I've been talking about? What about the greater wing of the sphenoid? Correct. As Ben says, it's enhancing. There's enhancement here. Look over here on the flare image. This the normal. Look at the high signal here. And look here, again, remember, as they say, fat is our friend in neuroradiology or in other parts of radiology. Here's a normal fat marrow of the greater wing of the sphenoid. It's gone here. Very subtle changes, but they were abnormal. There was a little bit of enhancement. And 1 month later, and this was prostate metastasis simulating a meningioma. What about this condition? People mentioned fibrous dysplasia or Paget's. I must say, I sometimes have trouble distinguishing the two. We thought it was Paget, but I agree. There's involvement here of the body of sphenoid. I think either one of them may be okay. Maybe it's more fibrous dysplasia. NF, I don't think this patient had NF. Here's a case from the literature showing what they call the Paget's. Looks somewhat similar to that, and this is one of our cases showing a meningioma. So there's definitely a distinction between the two. What is this pseudomeningioma? With possibly other conditions? Any diseases anybody wants to mention? Lymphoma, not bad. Multiple myeloma, Gino mentioned, and Anshu mentioned lymphoma, all very good diagnoses. I don't think you can tell. But as Gino said, this was a multiple myeloma. How about this? Another condition from the literature that has not been mentioned. Any other diseases? Okay, I will proceed. Oh, somebody's writing something. Langerhans, not bad, but this was a plasmacytoma. Another case, this was already mentioned before in the differential, lymphoma. What about this? Was mentioned before, it was a MET. This is a breast metastasis. What about this? Here I need a specific diagnosis, no guesses. Somebody mentioned thalassemia, Ewing sarcoma, warm but not hot. Correct. Asif hit the nail on the head. Here it is on MR. Marked expansion of the greater wing of the sphenoid. This is a baby. This was a metastatic neuroblastoma. Look at the marked expansion of the greater wing of the sphenoid. Here's another case. Same diagnosis, neuroblastoma. Look what has happened here. Tremendous expansion and soft tissue tumor along the greater wing of the sphenoid, encroaching on the orbit here, and you see the mass in the middle fossa. Look at the expansion of the greater wing of the sphenoid. Both cases of very young children was unfortunately neuroblastoma. And I want to finish with this case that I showed before. Always think meningioma. Again, here the hyperostosis of the lesser wing of the sphenoid was not appreciated. This was called a tumor of the nasal cavity, was operated on, and following surgery had a follow-up, and again we see the classic hyperostosis of the greater wing and especially the lesser wing. So CT can be extremely helpful, as I said. I think any unusual skull-based lesion should have a combined MR and a CT study to exclude some bony abnormalities. And this is the last case I'll be showing today. Thank you for your attention.